I'm afraid we will go further with the next presentation. It is Gerd Geerling from Düsseldorf, who's going to give a presentation on Fornix reconstruction. Do you hear me, Gerd?
Yes, I can hear you and I can see you.
And I just wanted to mention for all the participants, you can try to send your question and answers just by the function F&A. Thank you.
Dear colleagues, dear chairperson, thank you very much for inviting me to speak on Fornix reconstruction, established and evolving techniques. This is our department, and it's a good example of a lot of fornixes, because the fornix in Roman architecture is actually this arc structure in a triumph arc. But today we're talking about the fornix in the eye, and this is formed by the conjunctiva extending from the lid margin up to the fornix and back to the corneal limbus. Stephen Kay's group recently established that the conjunctival stem cells are predominantly located in the medial and inferior fornix. And I did this by staining for ABCG2 and P63 alpha, which are the stem cell markers here highlighted in brown, and they can be found as indicated in the nasal and inferior part of the fornix. So the fornix is the stem cell reservoir. What are the indications for fornix reconstruction? Now, there are a number of diseases causing fornix obliteration, trauma, tumors, but very frequently cicatrizing conjunctivitis is a result of inflammation, skin diseases, but also drugs such as in glaucoma causing pseudopemphigoid, or oculocutaneous syndromes such as the real mucous membrane pemphigoid result in fornix reconstruction. Here's an example of a patient with mucous membrane pemphigoid. You can see here that he has some basement membrane deposits of antibodies highlighted in this direct immunofluorescence, causing this inflammatory process and fornix shrinkage in the lower lid. He maintains good visual acuity at 0.8, but when this disease is progressing, the skin grows onto the cornea, leading to a fully keratinized and vascularized cornea and reduction of vision down to perception of light. When we want to reconstruct the cornea, we need a healthy conjunctival surface. Brought you here two cases of thermal or alkali burns, a 20 and 54-year-old gentleman. They had 360-degree stem cell failure, as you can see from these preoperative images with highly vascularized and cloudy corneas. Note that in one case with thermal injury, there was a number of oral mucous membrane grafts before, while in this alkali burn patient, there was only stem cell failure of the cornea. The conjunctiva looked rather normal. And in both cases, we performed the very expensive holoclar transplant, which consists of taking a little stem cell biopsy from the conjunctival, from the corneal limbus of the uninvolved fellow eye, expanding it on fibrin gel, and then transplanting this clear 100,000 K graft onto the corneal denuded surface. And here you can see that in the case with severe conjunctival changes and all mucosa graft, this holoclar graft of corneal stem cells failed. Only in the area where there was a healthy conjunctiva, also transplanted from the fellow eye, from the healthy fellow eye, some regular cornea could be seen. While in the patient with a normal looking conjunctiva, the corneal stem cell graft maintained perfect corneal clarity with very little neovascularization over a considerable longer time. So good conjunctiva allows corneal reconstruction and corneal limbal epithelial cells to maintain a healthy surface. So when we want to reconstruct the conjunctiva and we want to use graft materials, the basic principles and we need to remind ourselves of is that the conjunctiva consists of stroma and epithelial cells lining its surface. For fornix reconstruction, we therefore need such a stromal carrier matrix, which is lined by epithelial cells. If we have an acellular matrix, we need host stem cells, a reservoir, for example, on an amniotic membrane to maintain a stable conjunctival surface in the long run. The matrix itself will determine the biomechanical properties. For example, a stiff matrix will lift the lower lid, reducing exposure, while the cellular component will then decide whether we need to apply immunosuppressive treatments. If we have an allogeneic stem cell from a donor, we need immunosuppressants, while if we use allogeneic autologous stem cells from the host itself, then we don't need immunosuppressives. Standard materials are usually taken from the mouth or the nose or amniotic membrane. Bulbar and tarsal conjunctiva is rather limited. From the mouth cavity, you can use labial or hard pellet grafts. These contain no goblet cells and will not supplement tear film, but we can use labial minor salivary glands, which will provide some lubrication. When we use mucosa from the nose, the terminate can be used for extremely dry eyes because this contains goblet cells and will support a nocular lubrication, while the septal cartilage is rather rigid and can be used for lifting the lower lid in lid retraction. The amniotic membrane, as mentioned already, it has no cells, so we need a stem cell reservoir. It's rather fragile, but we have ample supply and we can use it for large defects. When we want to reform a Fornix, such as in this anophthalmic socket, we need to remove all scars and control inflammation so that the graft are not shrinking due to recurrent inflammation afterwards. Oral mucosa can be used to cover defects such as large as 2 centimeters. We can use full or split thickness grafts from the lip, as I told you already. Then we have to avoid the frenulum or the papilla here. Don't go too close to that, or the midline, because this, if we take hard pellet from the palate, we can induce little fistulas. We don't want that. If we want split thickness mucosa, we need a mucotome, but we can use that to trigger choose the thickness of our graft. We use thicker 0.5 millimeter grafts for the palpebral surface, which is not evident, while we use thinner, cosmetically more appealing split thickness mucosa for the bulbous surface. Both shrink, and this shrinkage or contraction process is most severe in cases after radiation or burns or mucous membrane pemphigoid. In these cases, we use the rather full thickness grafts, which shrink less. With the posterior lamella of the lid, we can also have to address aspects of the anterior lamella. For example, in this case with Lash ptosis, we did an anterior lamellar repositioning, as you can see here. If we want to reconstruct an entire lower lid with a free oral mucosal graft harvested from the lip, then we have to supply some vascularization to this, which can be done by skin flaps. You can see here several skin flaps used to cover this oral mucosa, and this can then reconstruct a full lower lid defect 1 month post-op delivery, a good cosmetic result. Now, alternatively, if we have very, very large defects, such in this case with an orbital invading squamous cell carcinoma facing the threat of orbital exenteration, this can also be excised rather than exenteration. But then we have a large conjunctival defect. This can be covered with large amniotic membrane grafts, specifically prepared for this purpose. And this will work because there is plenty of regular conjunctival stem cells remaining from the remaining conjunctiva and the lower fornix that is here maintained. And this case here is 4 years out, has good vision, has good cosmesis, and a normal looking conjunctiva. But we all know in cases of mucous membrane, while we have early on success in the long term in pemphigoid patients where there are no stem cells left, this will result in recurrence in the absence of stem cells. And also amniotic membrane, as it is rather thin, will shrink or dissolve. But Dane et al. Recently reported on the use of ultrathick amniotic membrane from the umbilical cord, which offers better stiffness and rigidity and dissolves less fast than the regular and transparent amniotic membrane. If you have a fancy laboratory, you can use cultivated oral mucosal epithelium that is expanded ex vivo on amniotic membrane to cover such large conjunctival defects. Here you can see the post-op result. We know now from a small group from Japan of 16 cases that in 30 cases with 10 years follow-up, they survive. No conjunctival shrinkage is observed, but in cases with inflammatory conditions, as ocular secretion pemphigoid, half of the cases showed severe recurrence of the Fornix shrinkage and scarring. If you don't have such a fancy laboratory here, such as in the case with advanced mucous membrane pemphigoid, you need to think of other options. This eye was blind. The fellow eye was developing severe cataract surgery. We had to reform the lower fornix, which was fused to the close to the pupil or the visual axis. In this case, we grafted all mucosa to the back of the lower lid after removing the adhesions to the cornea. We covered the cornea with an amniotic membrane graft. This allowed the oral epithelium grafted with the oral mucosa to expand on the amniotic membrane to form a stable epithelium. And then some months later, we could perform through the clear upper half of the cornea successful cataract surgery, leading to improvement of vision from 0.1 to 0.3. Then there's also a group of 7 cases with this technique reported by Sheffer Seng recently, and he showed that this could be successfully used to reconstruct and improve visual acuity in 7 out of 7 cases using exactly this technique with an oral mucosa to cover the back surface of the posterior lamella and an amniotic membrane to cover the bulbar surface, but he also showed that these cases, preoperative with severe corneal stem cell failure, showed recurrence of stem cell failure with recurrence of neovascularizations and opaque corneal epithelium postoperatively. So this oral mucosal epithelium expanded on amniotic membrane growing on the cornea will remain cloudy, as is the conjunctival epithelium, and it also will result in recurrence of corneal neovascularization. I'll ultimately show you a case of a patient with mucous membrane pemphigoid. In this case, we had performed osteodontokeratopacesis, giving this patient a vision of 0.5, despite recurrence of angular blepharon, and we had to address secondary glaucoma, and we did this by implanting a Bearwald implant, and for this we went straight through the lid margin because the lid margin was fused to the oral mucosa, and we dissected ourselves onto the sclera, implanted the Bearwald, implanted the supratemporal fornix, then placed the little tube through a little incision into the anterior chamber behind the keratopacesis, and at the very end of the procedure we closed the incision again, repositioning the lid margin straight to the keratinized oral mucosa. There's no fornix. Now intraocular pressure is reduced due to the Bearwald implant, and visual acuity maintained at 0.5. So let me conclude. The fornix is the stem cell reservoir. For conjunctival reconstruction, this is a prerequisite for corneal reconstruction. We need acellular matrices. If we use acellular matrices, we need stem cells, either from the host or a donor reservoir. And this is particularly important in amniotic membrane transplantation. Oral mucosa is still the gold standard for conjunctival reconstruction. We can use oral mucosa with minor salivary glands for severely dry eyes to give them some lubrication. We can alternatively use amniotic membrane and combine this with oral mucosa to expand the epithelium. But this is okay for conjunctival reconstruction. It will not allow corneal reconstruction. In any case, we need to control inflammation to prevent recurrence and contraction. And in the severest cases, we need keratopacesis surgery to bypass any fornix or opaque cornea. And ultimately, I'd like to remind you that the fornix in later Roman years turned into the brothel, which were working at night in those arcs. Thank you very much for your attention.
So, Gerd, thank you very much for having taken over a very difficult topic within ophthalmic plastic and reconstructive surgery. And we would like to give you the questions from the audience, but there are no questions at the moment. Coming to your talk again, the idea of having a artificial conjunctiva, this is for me or for all others has been the dream. Talking about these expanded conjunctival layers. So do you think they are working as we would like them to work? Because the amniotic membrane was a bit disappointing. So is that something for general, or is it only for very specialized centers like our Japanese colleagues?
Now, for one, there is no commercial product available. So you need an approved laboratory facility that is allowed to working to good manufacturing principles. So you need a highly specialized laboratory that is appropriate for producing advanced therapeutic medicinal products. And this is not provided in many places. And ultimately, so this, even in Germany, there is not a single laboratory that has the approval to produce such grafts. That answers your question, I think, easily. But what is the long-term perspective? We have this holoclar graft now, which is produced in Italy. And this is working in specific situations in the cornea, as I showed and demonstrated, when there's good conjunctiva. But a lot of cases in the trial for approval of this product failed because of bad conjunctival situation. So ultimately, it will be our goal and also our duty to convince industry that the conjunctiva is important enough to maintain visual acuity, so that somebody starts producing such a product at very large costs to be able to then later perform coronary reconstruction and to bypass such destructive surgery as cataract surgery. That's a personal opinion, but I think that's pretty much true.
So thank you very much. But there are perspectives, but obviously there's a long way to go. I would like now to give the microphone to Lelio. Maybe he has a question to Ganga. Otherwise, he's going to introduce the next session. Please.
Yes, Christoph, thank you very much. Can you hear me?
I can hear you.
Okay. Well, a question to Ganga is interesting, very, very beautiful talk, both of them, Ganga and Gerd, actually. Gerd offered us, we met Gerd 30 years ago, and he was offering 30 years, a distillate of 30 years experience, actually 3 years each minute of his talk. It is great, actually. It's great to have the privilege to hear all this information. Well, concerning Ganga, I would like to ask him if he have any experience. He emphasized the irrigation of the lacrimal system, and I want to ask if you have any experience concerning the difference that there are by irrigating the system with saline or maybe with viscoelastics. Viscoelastics are quite an anti-inflammatory, let's say, agent. They inhibit the factor that inhibit the migration of macrophages. So they favorite the decrease of inflammation following any surgical maneuver. So Ganga, do you have any experience, or you have experienced any difference by irrigating with viscoelastics or irrigating with saline at the end of your procedures?
Great question, Lelio. Personally, I've not tried experiencing or tried irrigating with viscoelastics. The only time I used to do it was initially when I was going through my endoscopic DCR learning curve. We wanted to inflate the lacrimal drainage system to have a large dilated lacrimal sac and proximal nasolacrimal duct. In terms of lacrimal irrigation, yes, in the past we were doing it more as a diagnostic procedure to find out about the soft stop, the hard stop, the nature of regurgitation material, to kind of find out whether it's a proximal or distal obstruction. And there were patients once in a while where we used to overcome obstructions with forced irrigation. And surprisingly, as you probably all remember, that there's a fraction of patients who would remain completely asymptomatic after irrigations. But in terms of post-drainage procedures, endoscopic or external DCRs, we don't do lacrimal irrigations at all because you can view directly with the nasal endoscope the fluorescein flowing through. But the post-ELDR patients where we have done an endoluminal lacrimal duct recanalization, those are the ones we do forced irrigation on a regular basis every 6 weeks or every 3 months, because we strongly believe that there has to be some kind of constant flow through the nasolacrimal duct to keep it patent. Otherwise, as the patients grow older, the tear production is less, the stasis within the nasolacrimal duct, which causes obstructions, recurrent obstructions.
Thank you. Thank you.
Thank you.
Well,